You are now watching the Quarterly Review Replay featuring Dr. Debi Dalton, sponsored by the Medical Association of Georgia.
I'm so happy to be able to introduce Penny Castellano, Dr. Penny Castellano. She is the president and the physician division and director of the Emory Clinic, and also professor of gynecology and obstetrics at Emory University School of Medicine. She was appointed president of the physician division and interim director of the Emory Clinic in December of 2023. She has strategic and operational oversight over all Emory Healthcare physician practices, inclusive of Emory Clinic and Emory Specialty Associates. She also serves as the physician liaison between EHC and the School of Medicine, and assumes all responsibilities as a chief medical officer. Dr. Castellano has been a faculty member of Emory University School of Medicine since 1990. She previously served as the associate clinic director and chief medical officer for the Emory Clinic faculty and Emory Specialty Associates, the employed non-faculty practice plan for EHC. She's also a professor and has been vice chair for clinical affairs and interim chair for the Emory Department of Gynecology and Obstetrics, which provides women's health services at 8 hospital campuses and multiple ambulatory practice sites in Atlanta. She received her bachelor's degree in zoology from Drew University in Madison, New Jersey. She received her MD from Emory University School of Medicine and completed her residency training in gynecology and obstetrics at Emory affiliated hospitals. So thank you, Dr. Castellano, for joining us tonight. I'm going to let you do a quick introduction about Emory Healthcare.
Sure. Thank you. Thank you very much, Dr. Dalton, and thanks to the Medical Association of Georgia for inviting me this evening. I will apologize for the quick screen flash a few seconds ago because I was realizing that there are a whole bunch of things open on my screen and did not want to interrupt us as we were moving forward this evening. So I'll go ahead without further ado. And for those of you who aren't familiar with the 2025 version of Emory, give you just a quick update of what we currently look like. So we currently have 13 hospitals and about 250 different clinic outposts. Many of our clinics are in large medical office buildings that are adjacent to our hospital campuses, but we also have a lot of very small, maybe 2 to 5 physician group sites across the Atlanta and Georgia landscape. Currently, our northernmost facility is a cardiology-based practice in Hiawassee. Our southernmost facility is a multi-specialty group practice site that is in LaGrange, Georgia. And then we have a number of sites in between. When you look at the statistics, for those of you who like to look at the numbers, this is what we look like. I always like to sort of interject that number of School of Medicine faculty can be a little bit deceiving because, first of all, most of our faculty are part-time clinicians. Many of them have research and teaching obligations. In addition, some of our faculty staff Grady Hospital, some of them staff Children's Healthcare of Atlanta sites. And so when we look at the size of the group that is associated with the Emory Clinic and Emory Specialty Associates, so those are our employed faculty seeing patients at Emory Healthcare, that is more like about 2,500 faculty members. And that number with their other obligations turns out to be about 2,000 clinical FTEs across our clinical landscape. Additionally, we, of course, have a variety of advanced practice providers, all together making up the largest academic practice in the state of Georgia. When you look at the things that make us a little bit unique, over on the left side of this slide, you'll see our School of Medicine statistics. And I think of note, we have about $750 million of research funding that is by and large mostly federal. Emory University as a whole crosses the $1 billion mark, but keeping in mind that we have a School of Nursing and a School of Public Health that also are participating in sponsored research. We have at any given time 40 years worth of medical students and then allied health students in our School of Medicine. So these are by and large our physician assistants. And then at any given time, we have about almost 1,400 residents and ACGME fellows that are learning and training within our organization. When you look on the right side of the slide, you actually see more of what the clinical delivery arm actually is, which is our employed and non-employed physicians, as well as our health network, which is our ACO that we utilize across the state. And just get a size, sort of a feel for the size of the organization. Now, when we look at our practices specifically, we do about 5 million encounters per year. And so that includes clinic visits as well as things like lab visits and imaging visits. When I look at patients coming into physician offices every day, we do about 11,000 patient visits per day. And then looking again at our FTEs, anywhere from 1,500 to 2,000, depending on how you slice the organization. And this is just for the physician group itself. And then again, just to give you an idea of how we are spread out across the state of Georgia and how we interface with some of our partners, we do have affiliations with a couple of different groups across the state. When you look at this map, the blue stars are our owned hospitals. The pink squares are our owned practice sites. And we actually had to make a little piece of the map so that you could appreciate where LaGrange is. So I think that gives us a pretty good overview, Dr. Dalton, of Emory as an entity.
Great. Thank you so much for giving us that overview. And so obviously Emory is a very large and very important healthcare system in Atlanta and in the area, and of course beyond that as well, as you showed on your map. So I'm sure Emory also has experienced shortages within the healthcare workforce, just like other systems have. So can you talk about what that looked like for Emory and what they're doing about trying to mitigate the issues with workforce shortages?
Sure. So I always have to remind people when I'm speaking to people from other parts of the country, how unique Georgia is as a state. So when you think about how we look sort of geographically and demographically, we have about 11 million citizens in the state. 6.5 million, probably approaching 7 million, are in the metro Atlanta area. So that leaves a much less dense patient population throughout the rest of the state. And when you look at the way that our counties are situated, and I have to apologize, I don't know what that red line is, and I will try not to make it any bigger, but
That's okay.
When you look at the way that our counties are situated, we have almost 3 million of our state population living in underserved areas. So this map to your right shows the dark blue as being health professional shortage areas. And note that 143 of our 159 counties in the state qualify for that. So that in and of itself sets a stage that is a huge challenge if everything is flowing correctly. As an OB, formerly practicing OB, but still current OB/GYN, I have to remind myself every day that half of the counties in our state do not have a practicing obstetrician. And so there's little guesswork about what our challenges are from a provider perspective. Now, when you take that as the foundation and put across it a couple of facts, it can actually be pretty anxiety inducing. So first fact is that our population is aging. We do very well at managing comorbidities in the aging patient population. What that means is the portion of our patients who will be over the age of 75, let alone over the age of 65 in the next 10 years, is increasing more than linearly. So it's not quite exponential, but it is certainly more than a slope of 1. The other piece of information and fact that is a little anxiety inducing is that our physician workforce is actually aging. there is a delay in retirement age. Maybe saw a little reversal of that right during the worst of the COVID pandemic, but by and large, our physician workforce works past the age of 62, the age of 65, and the age of 67. So depending on which one you want to landmark as retirement age. Now, I think the most sobering of statistics that I've seen in the last 2 years was a statistics shared by the AAMC, so that's the American Association of Medical Colleges. And what they have been able to determine is that for each retiring full-time physician, we are actually having to replace him or her, with 1.7 FTEs of newly minted graduates. And there are reasons for that. But when you think about what we have previously just assumed was a one-to-one replacement, somebody retires, we bring on somebody to replace them. We actually need to do that differently as we are moving forward. So increasing demands from our patient population and an increasing need to expand our workforce. Now, why is that it's not one-to-one anymore, that it's more like 1 to 1.7? There are reasons to understand that most of our graduating residents and fellows have basically been, they have been trained on an 80-hour work week. Now, I'm the last person to say that we should be doing something different than that, because there are certainly safety science reasons to limit someone who's training and making sure that they are not overburdened both cognitively and physically as they are learning. So the 80-hour work week has been pretty stable and some good evidence around it as being something that should be perpetuated. Unfortunately, when you're used to an 80-hour work week, the thought of then suddenly changing the balance of your work and life proportions is not really acceptable to a lot of our team members. They would like to maintain something that is more like an 80-hour work week, and call burden is factored into that. And continuing to focus on managing stress well, having time for family and wellness is really important to the generation that's coming on board as newly graduated trainees. And so it is really unlikely that we are going to see this shift in a different direction. So as we look at the new cadre of people who are going to be taking care of patients and helping us in all of our health systems, how do we approach this? Because there's not certainly a huge surplus of folks graduating from programs. So there are a few things that are in play right now as approaches to this. Number one, pipeline stabilization. So thinking about ways to expand educational opportunities. We have a lot of medical schools that are starting to increase their class size. There is much movement afoot to expand the GME opportunities for trainees. Some health systems are not relying on federal funding to add training slots. We do have different specialties that are adding fellowship years so that folks are a little bit more able to hit the ground running when they have finished their graduate work. And then retaining your trainees. So if you are in a system that is able to produce people who are coming out of residency or fellowship and able to provide care competently in your market, community, or state, what can you do to retain them in your state? So one of the things that we are really focused on at Emory is making sure that we are giving people opportunities to populate our state. Some want to be in rural communities, some want to be in metro communities, but making sure that we've had those discussions and that we're networking with practices and areas where there are opportunities for our graduates to stay in Georgia and be able to provide care. Sometimes people will leave to go get that super specialized training, and then being able to attract them back to the state is something that a lot of our departments have spent time really focusing on. Now, thinking about how do we manage the work-life balance needs of our new and younger physician attendings, and making sure that we're able to manage that. One of the things that we have had come to us in sort of waves in our faculty and non-faculty practices, from what I've been able to discern from my colleagues elsewhere across the country, there is a trend for our folks who especially are in that first 5 to 10 years of practice to ask to not be full-time. Now, why might that be? Well, if I think to the way that it worked maybe 15, 20 years ago, we didn't have electronic medical records. We didn't have in-baskets that can sometimes seem to have an infinite amount of traffic of messages that need to be answered by patients that you have a relationship with. The burden of putting a lot of administrative information into a note, for those who don't have any ability other than typing to enter that data, that burden is real. So 20 years ago, we didn't talk about the phenomenon of pajama time, which is what people do between 7 and 10 p.m. to finish their notes from today, sometimes in front of a home computer, sometimes on a laptop, but that didn't exist before. And then, as I said, the in-basket burden has created a real work burden for some of our, especially primary care docs, but even some of our really super specialists. And so figuring out how to manage that, some of our younger attendings have just said, I just want to be a 0.8. I will take less in my comp. I want less time that is like scheduled for me, and I'll take that extra day to just ease those burdens. So when you have a large number of people asking for that, you've now got to figure out how to manage your whole workforce. So how do you keep your office open? How do you manage call schedules? How do you manage staffing schedules? Those folks may really need to be full-time. And so there's a lot of balancing that goes on with that. What we have realized is that we actually have to figure out ways to support those asks, because in the event that we don't, our younger attendings are just going to go somewhere else. So we want to retain them in our practices. We want them to feel like they have time and ability to stay well, and that they're able to really balance work and life together. Some of the things that you see nationally is that there are programs that are being sponsored specifically by the AMA that are focused on reducing that administrative burden for our providers. How do we utilize the staff in our office to create good workflow in the office? Really, the focus, I think, started with the Institute for Healthcare Improvement many years ago, thinking about the joy in practice. How do we reinvigorate practice activities so that our physicians feel like they are contributing positively to their patient's experience, and that they are being fulfilled by what they're doing? And so you'll see Steps Forward and the AMA Physician Wellbeing Program. Both of these are easily searchable on the internet, and they actually have very specific toolkits for how you can start to modify your practice to recreate some of that physician health. Of course, all of our health systems have employee assistance programs. Most of us have peer support programs. Those are helpful, but they really don't redesign your day. And what you're really looking for is ways to redesign your day. So some of the things that, again, we are hearing nationally, we have done a few of these things at Emory, but we don't have huge experience in some of these. So there are now practices that are actually hiring virtualists. So these are not specialty specific opportunities. We've seen this in everything from super specialized neurology to general primary care. These are physicians who don't see patients physically in an office. They only do virtual visits. And there are opportunities for some of these in on-demand requests from patients, in follow-up after a hospital discharge, or for patients who need close monitoring. In-person visits may not be necessary. Having somebody dedicated to this might be a way to fulfill their joy in practice, manage your patient population, and unburden the physicians that you have in their offices. Of course, we've all seen hospitalists, nocturnists, laborists. There's a bunch of new different names that really focus on more shift-based work, where you stay focused and very active for maybe 8 to 12 hours. And then after that, you're off, and then somebody else comes on board. Pluses and minuses to that. We all know that handoffs are a risk point, but this tends to be something that actually helps to focus intense, busy work and keep it safe and keep the providers healthy. And then the newest thing that I've heard of, we do not have any of these at Emory, are in-basketologists. So for those of you who are burdened by the never-ending flow of messages from patients, there are some practices that have actually hired people, some of them APPs, some of them physicians, to just manage the incoming in-basket. So no experience in that, but I wanted to mention it because I've heard of it. And then lastly, I'll just share that, there are approaches that we can take from an advocacy standpoint. Certainly the Medical Association of Georgia can play a role as we are looking at the way that we are challenged based on our geography, our demographics, and where our patient populations live. The AMA doing the same thing in many of our specialty societies, really pushing for expansion of training programs and the ability for us to maybe leverage folks to be on our teams in ways that we haven't thought of before. The one thing that I will mention is that some rural areas in Georgia, but also in other states, have employed community health workers. These are non-licensed, non-clinician educated folks who are able to just be liaisons, to reach out to patients who need to come in for an appointment or set up a virtual visit. One of the things that I think we ask ourselves daily, and I don't have really an answer for this, but the question of teaching resilience to our teammates lingers out there. How do we bounce back after having to work more than 12 hours? How do we stay safe? How do we show up for our families even when we've had a stressful day at work? That is a question that a lot of different authorities and research groups are trying to address right now. If we can find a good recipe for that, I will be the first one to share that with the group. So I hope that's helpful from the workforce standpoint, Dr. Dalton.
Yes, thank you. And you mentioned virtual. So let's talk about virtual medicine. How does that fit into the plan? Give us a little bit more detail what that looks like.
Yeah, so virtual visits was something that I think we kind of thought we had an allergic reaction to until March of 2020. And we quickly learned in about 4 days how to do virtual medicine. And I think what we have learned over time, and you can see that that some virtual medicine has truly been an adoption that has stuck since the COVID pandemic, and then some of it has kind of waned off. When you look nationally, everybody was in the 80% range during the height of the pandemic, and most health systems, if you look at them multi-specialty view, are somewheres in the 10 to 15% range currently for virtual visits. Now, it differs by specialty. We have seen that some specialties actually do really well with virtual visits, and you can leverage your provider population in different ways. Behavioral health, we are still seeing almost all of this done virtually. And there are so many good reasons for that. Number one, it's easy for patients to keep their appointments. I think something that is really interesting for those of you who maybe have not had a lot of experience with virtual visits, there is something so enlightening that you learn when you see a patient in their home environment, you quickly understand, oh, there may be some challenges with the location, with transportation, with the way that the household is set up, with fall risk, with ability to take meds. So I think that there's some insight that we gain that we don't appreciate when patients come into our environment. So I think behavioral health is going to continue to leverage virtual medicine for a lot of what they do. Interestingly, for both imaging purposes, and that would be like radiology imaging, but also even photograph purposes, there's a lot that can be done in radiology and even ophthalmology virtually. So quick aside, we know that patients with diabetes should have their retinal exam every year. What we are seeing now is a trend for patients with diabetes to get their retinal exams done virtually. It is easier than getting into an ophthalmologist if you don't have an already established relationship with one, or may live in an area where it's difficult to find an ophthalmology practice. You can actually go into some of the retail clinics, get a camera that will take the picture of your retina, send it to a virtual team that will look to see if you have retinopathy, and then create the fire alarm and send you on to the ophthalmologist. So these are uses that I say here that they're lingering. I think we've learned how to use virtual visits and been able to actually use them for good care. Follow-up visits after hospital stays. I don't know how many of you would feel really excited after being in a hospital for a week to be told, go home, make a phone call, and then come back and see us in 3 days. It's so nice to be able to do that visit virtually, unless the patient needs something, physically checked. And again, to be able to say, do you have any questions about your meds? Again, something magic when a patient holds up the 2 statins. This is the one I was taking. This is what they sent me home with. Do I take both? You can quickly clarify that for a patient. And then another place that we still feel like we're able to leverage in constructive ways virtual visits is for initial consultation. So if a patient lives very far away, they have something that is complex and needs a really super specialized consultant to help them decide surgery, no surgery, what kind of meds. They may not feel comfortable making a 2 or 3 hour car ride as the initial meet and greet. Being able to do that virtually gives patients at least an understanding of, here's the provider that I am going to see, and I feel comfortable that this is a person that I would be established with then going forward. So then the car ride might not seem so daunting. Then I think we have found all sorts of new uses for virtual care. And I think we see this put in play in varying ways across the country. So we talk about virtual nursing care at Emory as a couple of things that we're experimenting with and finding are helpful. So fall prevention, think about the way that we do telemetry traditionally. You have someone sitting in a space with, it could be up to 20 telemetry monitors watching to make sure that they know that everybody's got safe rhythms. Similarly, what we're seeing is that there are ways that you can use cameras. These are not cameras like the ones we're using right now. They basically give you outlines of the human. They don't show you the face or anything in detail, but they're able to create an alarm when the human moves in ways that indicate they are trying to get out of bed. And if you have somebody who's a fall risk, having that alarm go off may be much more of a preventive strategy than waiting for the patient to ring a bell or going in repeatedly to see if the patient needs help. So we are thinking that this might be a really important use of virtual capabilities as time goes on. Virtual sitters, a similar perception. Having somebody sit in a room with a patient sleeping is not great use of their time or skill set. Having them able to do 2 or 3 patients at a time might be a better way to move that forward. And then you can actually take that all the way down to things that are really sort of that redundant safety net. So having someone who is monitoring a whole unit of ICU patients virtually while your nursing staff and physician staff are attending to those patients one at a time, it just gives you a safety net of, oh, somebody's O2 has started to desat. Do we need to do something different? We have somebody who's tachycardic who wasn't an hour ago. It just increases the sensitivity of that observation. And we're seeing that these sorts of strategies can be used in your clinical decision units, your observation units, and to even be able to provide a quick inpatient consultation when your consultant might be at another hospital. So one of the things that I try to make sure we do is prevent having valuable physician time spent on highways in traffic. And so being able to quickly provide consultative care, look at a strip, be able to assess some of the patient's vital signs actually is really helpful. So let me pause there, Dr. Dalton, because I think we may have a few more things to talk about, but I think that sort of sums up how we are leveraging some of our virtual care currently.
Great, great. Thank you for all that information. So I see your slide has innovation. So let's talk about that. Emory is definitely a leader in healthcare innovation for sure, and it's got a great reputation. But let's talk about safety and quality goals that Emory is going to use innovation to improve on those safety and quality goals.
Yeah, so I think we have sort of three streams that would really contribute to the way that we innovate. And so I'll actually start at the bottom. I mean, we're doing clinical research and basic science research every day. And so we are fairly familiar with, I would almost even say comfortable with, discovering ways that we can use a medication differently or approach patient care differently. I mean, one of the things that I think we sort of realized fairly early in the COVID pandemic is changing the patient position in the bed actually made a difference. And so being able to recognize that you've got something that creates a difference and then being able to spread it is an important feature of how you manage innovation. And realizing that some of the things that you do may not make a difference, and you certainly want to declare them as not helpful fairly early on. From the approach of safety and quality, what I think we, as well as a lot of our peers, both locally and nationally, are realizing is that there are things that sort of hide from view that create safety problems for our patients. They could be a result that didn't ever get to the ordering provider, a message that didn't ever get to the patient, something that needed follow-up, and the patient moved. And so we don't know whether or not the patient got the follow-up that they needed. And so thinking about how we use both humans and technology to manage some of that is really important. So let's talk a little bit about technology and its uses there. And I'm going to say the magic words of or letters of AI. So how we manage AI, the artificial intelligence across healthcare is something that we all should be paying attention to. There's a lot of desire to just implement quickly. And for those of you who haven't heard this explanation of AI, I mean, we've been using AI in medicine for a long time. We've been overreading imaging and pathology slides with AI algorithms for quite some time. What the generative AI, which is ChatGPT and its peers, does is it actually looks at sentences based on everything we've given the tool to digest, and it predicts the next set of words. That's kind of the rudimentary way that that generative AI works. But being able to leverage that in new and different ways is huge. And we've gone from generative AI to both new tools, including both ambient and agentic AI. So let me give a quick overview of how we can use these to manage some of the things that we've already talked about. So we were one of the first groups to implement ambient AI in our physician practice offices. What it does is listen to the conversation between the patient and the physician, and it writes the note. Now that seems somewhat magical. You have to actually have a valid tool to do this. You can't do it with ChatGPT, but if you do it with something that is designed to actually execute that task, what we have found is, sort of multiple benefits. Number one, our notes are better. We capture detail that people would leave out all the time. Number two, the satisfaction of the physician and provider staff has been amazing. I actually got thank you notes from people who hadn't eaten dinner with their family in years, that they actually said, like, my life is like different. I don't even know how to explain how much better my joy in practice is. So I think that there's real potential for ambient AI to become our norm over time. Most of the commercially available electronic medical records are starting to embed this in their tools. So this is probably how we will work going forward. The generative AI, it was able to write a letter for somebody you wanted to write a recommendation for. It's gotten smarter now. And most of the electronic medical records are now using generative AI to read the chart for you quickly. So for those of us who remember when charts were paper, you would know whether or not you had a young, healthy patient or an older ill patient in front of you by looking across the room at the chart. If it was this big, you were going to take a minute to have to understand what the patient had as conditions. If it was really thin, you knew that the patient was either new or healthy. It's very difficult to get that feel when you are in an electronic health record because you basically see a screen. The screen may have a lot or a little on it, but you see one screen. So there is no way that you can quickly digest 30 years of a patient's history in a screen of an EMR. What the generative AI is able to do is it's able to quickly go through the notes. You can program it to do your specialty. You can program it to do everything. You can program it to do just pathology results, but it allows you to then digest a whole lot more of the patient's history quickly so that you don't forget things. So from a safety perspective, you've got an ability to do a better note, remember things that you might have forgotten if you were typing the note during your pajama time. And from the chart summary perspective, you actually have an opportunity to not miss things. And then I'll say a word about agent AI. This is sort of the bleeding edge of this technology, but this is where we actually teach the agentic bot, if you will, to do something like the customer service bots do when you chat or call some of the retailers. You're not talking to a human. It's really cool because it makes it sound like they're typing. They're not. This is just part of the background that's native to their bot. But what we're now learning to do with some of this technology is to do things like pre-op conversations with a patient to remind them, don't take this med, take this one instead. Don't forget to bring a driver. Don't forget to do your pre-op meds. So being able to have that conversation and ask the patient, do you have any questions? And then have the patient be able to ask the question and the bot be able to coherently and correctly answer the question is sort of the next frontier. So we're really excited about this being able to help us from a safety perspective. A lot of people, have asked the question, well, are we just going to replace the humans? I will be the first one to tell you there are not enough humans to do all the steps that keep our patients really safe. And so being able to augment some of that safety steps is really going to be important as we go forward.
It sounds like it's going to improve CDI and data collection as well too.
Yeah, I think we'll learn how much we can teach the AI tools as we go forward. And I'll just close with just some things that are a little bit future, but I won't be surprised if we see this as we move forward. There's a lot of question out there. If you just Google AI and surgery, you'll see pictures on the internet of robots doing the surgery, like robots like C3PO, not like a Da Vinci robot. And I think that's pretty far-fetched. However, what we are starting to see is companies that are teaching AI how to watch a surgical procedure and remind the surgeon of safety steps, or look to see whether something is really aberrant in the anatomy to tell you, hey, don't forget to look at this, or don't forget to check this. We're seeing AI tools be smart about how we schedule everything from an OR to an infusion chair to an office practice. And then if we have processes that are important for safety, like we saw a lung nodule on an X-ray that was actually done to look for a pacemaker placement, don't forget the lung nodule. How do we make sure that that process gets done? So the future is maybe a little bit scary, but I think right in the thought process that we'll be augmenting all of our human processes in ways that that hopefully will make our care better and our care safer, and maybe most importantly, allow physicians to actually concentrate on medicine and judgment, which is where the AI actually can't do the job for us. So I think that was my last slide, Dr. Dalton, and I am happy to talk more, answer questions. I want to be sensitive to time because I understand that everybody has their work-life balance to manage.
Absolutely. Well, thank you so much for all that information. There were a couple of comments in the chat. There was a comment about how this was a very eye-opening presentation and what's in store for the future of medicine. It's very important information. And that Dr. Rathkopf mentions that ambient AI has made her clinic documentation so much easier, but that bubble burst when I was asked how many extra patients I would be willing to see to offset the cost of the software.
Yeah.
And I think that usually is something that the facilities and the systems would probably just take care of. And then Dr. Goldman asked what program Emory is using and how much per physician.
Yeah, so we do everything at the system level, so I actually can't give you the calculation. We currently use a software program called Abridge, and it's been available nationally for about a year and a half. And we actually have been using it pretty much for about a year and a half now.
Okay.
And yeah, so for Dr. Mitchell, I am going to tell you that I had a slide from AAMC that showed that ratio. I looked high and low because I wanted to put it in my slide tonight, and I cannot find it. I will try to find the source for that and share it with Dr. Dalton, and we can send it out by Donnie for the team. But I actually had the slide in a photograph. Cannot remember it, but I remember walking out of that presentation thinking, oh, we're in trouble. We don't have 1.7 for every person who's retiring.
And Dr. Rathkopf mentions that Children's has piloted Abridge and DAX and just decided to go with Abridge. I know Wellstar is using DAX right now. They're piloting DAX. And Dr. Mitchell says, great presentation, a lot we already know, but great to have that information though, for sure. Yeah, I remember when smartphones were kind of scary for some people, and nobody wanted to adopt them initially. A few early adopters, of course, but a lot of people, the general public, was kind of like very scared about that. And I think if we learn how to use these tools properly, I think it'll be great for us. And I think we have to be part of that solution as well.
Yeah, and I think always always being curious and asking the tough questions. I think we've all seen programs and software tools that have a glitch that we realize later, oh, now we have to go and fix that. We certainly don't want to lose our clinical skills. You need to be able to kind of write a note or be able to say what you saw. And so I think there is, sort of a little bit of a double-edged sword. It's always interesting if there is any kind of a power failure or a downtime at any of our practice sites. We're still talking about, we'll just do downtime procedures. Just write a prescription on a pad, and everybody giggles and says, I don't know how to do that.
True, it's very true. Very true. All right. Anything else you'd like to add that I didn't ask about?
I don't think so. I think I would just say we all need to sort of watch the national landscape. I think we'll learn about things that are definite helps to all of us in our practices. I think the landscape will continue to shift a little bit, and we should be as kind as we can to our associates as they join our practices, because they are still learning a lot as they finish their training.
True, true. And all these tools are very important to make life as a physician a little bit easier, a little bit better, and for our patients too, because
Sure.
it gives them a little bit more information than we are able to give them as well sometimes. Well, thank you so much, Dr. Castellano. That was great. I really appreciate you taking the time to meet with all the MAG members who joined us. Everybody, I just want to remind you about the House of Delegates on October 17th. I hope to see you all there. We got a lot of work to do, and I hope you have a great night.
Thanks again, Dr. Dalton, and to everyone at MAG. It was my pleasure tonight, and please feel free. My email is available if anybody has any questions. Happy to answer them later.
Thank you so much.
Thank you.